Hi, my name is Mary Rose Alonzo-Gatti. You may also call me Isabella, and this is my medical family therapy project presentation. McDaniel, Doherty, and Hepworth coined the term medical family therapy to refer to a form of professional practice that embraces a biosocial approach, mind, body, family, community, and systemic family therapy principles in the collaborative treatment of individuals and families experiencing physical health problems. It emerged in the late 1970s and early 80s from its parent discipline of marriage and family therapy to address the gap in the healthcare system between biological and psychosocial health. A basic premise of medical family therapy is that there are no psychosocial problems without biological features and no biomedical problems without psychosocial features. Engel, who developed the biopsychosocial model, challenged the medical orthodoxy that at the time was reductionistic and focused solely on the disease of the person. He believed that a biomedical perspective limited the understanding of illness, offering an alternative perspective that the person's body, mind, relationships, and social context interact and influence each other continuously. He addressed a significant gap in the way in which the medical model was seen when treating patients. The biological component seeks to understand how the cause of the illness stems from the functioning of the individual's body. The psychological component model looks for potential psychological causes of a health issue, such as lack of self-control, emotional turmoil, and negative thinking. The social component of the model investigates how different social factors, such as socioeconomic status, poverty, culture, technology, and religion, can influence health. Several other mental health disciplines provided psychological and relational services in medical settings, but the intensive training that medical family therapists received in applying systems theory to their work with individuals, couples, families, and healthcare providers across settings offered something essential and unique. Clinical, academic, and administrative professionals in the healthcare field began to recognize the importance of collaboration between medicine and behavioral health, which resulted in the growing relationship between family medicine and marriage and family therapist practitioners. Later, the biopsychosocial approach was expanded to the biopsychosocial spiritual after medical family therapist pioneers recognized the importance of including spirituality in whole person care. According to Peake, in order to impact healthcare, four worlds must be addressed: the clinical, operational, financial, and training, also known as the four worlds of the four worldview. The first world is the clinical world. The clinical world is focused on the type and quality of care, whereby the unit of analysis is the patient. This clinical world captures clinical activity and the achievement of health goals within the patient population. In the clinical world, providers interact with patients to assess, diagnose, and provide treatment, and is relational and occurs in interpersonal interactions between providers and the patients that they help. The second world is the operational world. The focus of this world is in the consistency and reliability of policies and protocol, such as how care is provided and if the care delivery is well executed. In the operational world, the operations, production, process, and system improvement of the practice are considered. Some key factors are the processes and infrastructure involved in scheduling patients, billing, and inserting codes, referrals, and the electronic medical record. Medical providers mostly function in the clinical world, but a good relationship between providers of the clinical world and the staff and administration in the operational world is critical for its success. The third world is the financial view. The unit of analysis is the numbers related to the business and financial return of the practice, and the focus is the price and value of care and the accounting activity related to integration. This may include sending bills, collecting money, and tracking the outflow of time, materials, and money. The fourth is training, which is equally important because training needs will be substantial for primary and behavioral health providers. Educational training programs will be crucial in providing an adequately trained behavioral health provider workforce that can meet the new integrated model's demands. Training is equally important as there are unique needs that MedFTs must consider in their development. Four main elements that MedFTs need to consider during their training are an understanding of the medical culture, educating themselves to fit into the medical system, investigating patients' biological needs, and paying special attention to self and the therapist issues. It is by immersion into the medical culture that MedFTs learn how the biomedical perspective to patient health is different than the traditional mental health framework. Only with respect for a variety of healthcare providers, disciplines, and cultural differences can MedFTs successfully integrate themselves into a medical setting, which can be emphasized through this type of training. Primary care providers and MedFTs need effective and easy to use tools to assist them in delivering measurement based care. Using standardized tools such as the PHQ-9 and GAD-7, screening for depression and anxiety, and validated screening tools for substance use disorders can help normalize addressing behavioral health in routine primary care and increase identification of behavioral health issues. Behavioral health screenings combined with streamlined workflows on what providers should do with the results can facilitate timely and effective linkage to appropriate treatment. Follow-up of PHQ-9 and GAD-7 can also assist in monitoring progress with treatment. The PHQ-9 is an abridged version of the patient health questionnaire portion of a larger assessment called the PRIME-MD, which was designed to screen for depression, measure the severity of symptoms, and measure a patient's response to treatment. It asks questions to patients to speak about how much they have been bothered by 9 problems over the previous 2 weeks. 9 items in the PHQ-9 are based on the 9 diagnostic criteria for major depressive disorder in the DSM-4. Examples of problems covered by the PHQ-9 are feeling tired or having little energy, poor appetite, or overeating. Each of the 9 items can be scored from 0 to 3. 0, not at all, to 3 is nearly every day. It makes for an attractive dual-purpose instrument for making diagnosis and assessing severity of depressive disorders, particularly in the busy setting of clinical practice. It has been validated in primary care environments and used successfully in behavioral health centers, and it can be self-administered or clinician-administered. It's also used to diagnose and identify problem symptoms at the initial visit for depression care, measure treatment response, and identify specific symptoms are not responding at the follow-up visit. A limitation of this tool, though, is it only provides a provisional diagnosis. Therefore, a follow-up interview must be done to arrive at an accurate diagnosis. If the screening test is positive, further evaluation is needed to confirm that the patient's symptoms meet the DSM-4 criteria and to rule out any other causes for symptoms so that an effective treatment plan can be created. What to consider in a follow-up plan for a patient who screens positive? Follow-up plans should take into account the severity of the symptoms and their impact on functioning and well-being, patient preferences for types of treatment modalities, example, medication, or versus individual versus family therapy versus group therapy, and evidence-based guidelines for effective treatment. It is also essential to initiate a collaborative conversation with a focus on shared decision-making and inquire about patients' preferences. The ability to address a patient's treatment preferences has been shown to be related to the likelihood of engaging in treatment for depression and better treatment outcomes. For patients who are not open to a certain type of treatment, it may be helpful to inquire why, so the provider can learn about the patient's values, beliefs, and prior experiences with mental health treatment. An open, trusting, empathetic relationship is a required element for patients to be vulnerable about their depressive symptoms. Is in many cases a chronic disease that requires self-management by the patient. Psychoeducation is essential whenever possible. Psychoeducation should also be offered to involve family members and significant others. The patient's consent is generally required before such information can be shared. Topics should include the cause and typical symptoms of depression, treatment options available, and the process of finding the best fit for the patient. Expectations to guide a course of treatment, monitoring symptoms and side effects of treatment, protocols for following up with primary care office or any community resources. Example, a crisis hotline or an on-call physician for after-hours support. Early warning signs of recurrence, and communicating about depression with family members and friends. ICSI offered recommendations for considering medication or psychotherapy as frontline therapy options for patients who screen positive for depression based upon their score on the PHQ-9. And of the multiple behavioral interventions in existence, only a few have been proven to work in primary care, including problem-solving therapy, primary care, cognitive behavioral therapy, interpersonal counseling, and behavioral activation. Problem-solving therapy primary care is the most widely used intervention to treat depression and anxiety in a primary care environment. It is a brief therapy that uses 6 to 10 30-minute sessions to help patients solve the here and now problems contributing to their depression.
It has been found to significantly improve mental health treatment in a wide range of settings, including diverse provider and patient populations. An adaptation of cognitive behavioral therapy has also been found to be beneficial for both depression and anxiety in primary care. CBT uses short-term goal-oriented therapy to interrupt patterns of thinking that prevent patients from feeling better. Brief CBT makes the intervention more accessible in primary care by using shorter and fewer sessions.
While the behavioral interventions I have mentioned have been proven to work in primary care, they all have constraints that make them difficult to implement, such as the amount of training and ongoing supervision clinicians need, not to mention the time demands needed from patients. The question, how do we adapt these behavioral interventions to many social locations? We need to create new interventions from the ground up. We need interventions that are personalized, easy to learn, and easy to deliver in the settings they are needed most. I think we need to focus on developing behavioral interventions in low income, ethnic minority, and older populations implemented in non-specialty settings, such as, primary care, assisted living, senior services, and day treatment. As primary care providers and medical family therapists, I think we have the potential to significantly reduce the global burden of mental health conditions if we can create nimble, adaptable, innovative solutions that any clinician can provide and that are acceptable to a broad array of patients. An aspiring medical family therapist like myself who has worked as a counseling psychologist sometimes emphasizes the individual factors if only an individual presents for therapy, eliminating relational context that may shape the client's thoughts, feelings, and behaviors. I must acknowledge that systemic principles can be used to understand an individual, and as a systemic therapist, I recognize that our clients often find themselves caught in relational patterns that create problems for them even in cases where individuals are labeled as having an individual problem, considering relational context is still important. For example, an individual with alcohol use disorder with supportive family members can be a protective factor. Conversely, families can influence the course of an illness. Individuals with schizophrenia are more likely to relapse if they have hostile and unsupportive families. It goes without saying that when it comes to treating families, it is crucial to explore the presenting complaint while at the same time challenging the family's certainty that the problem lies exclusively on the identified patient. Broadening the focus from the identified patient to relational patterns, exploring how family members may perpetuate the presenting problem is imperative. I want to extend my appreciation to those who listened and to the healthcare team in Texas for welcoming my additional expertise and support. Thank you.